Okay, so we're looking again at the image showing you the differences between the different type of vertebrae according to region. So if you recall, I said before that vertebrae changes depending on the region, and one of these major changes is seen in the body of the vertebrae. The body of the vertebrae is this part that faces anteriorly and that is separated by the intervertebral disc, and that specifically it is having the function of carrying the weight of our body. So then, because the vertebrae that we have in our neck carry only the weight of our head, the body, it is less thick than the ones that will be below. And then as you move from the cervical vertebrae into the lumbar, this body becomes thicker and stronger. So you can see it in here. So this is a small body from the cervical vertebrae. This is the cervical vertebrae, the top view. This is the thoracic vertebrae, so it has a medium-sized body. And then this is the lumbar vertebrae, so it has more massive body. Now, a major characteristic of the cervical vertebrae, it is that it is the only vertebrae that has transverse foramina. So it has holes in this part, which is the transverse process. This transverse foramina help for vertebral arteries to come into the brain to provide blood supply to the posterior region of our brain, and also, or regions of our brain, and also carries the vertebral veins. So the ones that drains the posterior area from our brain. So this is very characteristic of this vertebrae. The spinous process, which is the process of any type of vertebrae that faces posteriorly, that you can feel when you touch your spine, this, it is short, and the angulation is a little bit downward, but not as much. It's almost horizontal, and it has the bifid spinous process. So sometimes this is split, so it's a characteristic. And then the vertebral foramen, which is this, is triangular. Now, within the cervical area, we have two vertebrae, the atlas and the axis, that are very specific to this area, and they have this specific name. Atlas is the only vertebrae without a body. And then the axis has a pointed projection that is called the odontoid process, or the dens. This dens articulates with the atlas in the anterior, in the anterior arch, in the part that is internal, so that you can rotate the axis over the atlas, like saying no. And this process is easily broken when someone has a traumatic injury in the neck area or in the head area posteriorly. That traumatic injury can be a whiplash accident or someone falling from, for instance, a horse, like what happened to Christopher Reeve. In my opinion, the most handsome Superman actor that has existed. And then, unfortunately, he was left after this injury, so he fell from a horse. He broke his odontoid process that went into the spinal cord. That affects so much the spinal cord that he was quadriplegic. He couldn't move from the neck down. And then eventually with time he died. But sadly enough, people can become so damaged their body out of this type of injuries. Now, for this thoracic vertebrae, it has a medium-sized body typically is round, and as well the vertebral foramen, which is this, is round. The transverse processes, they don't have a transforamina, however, they have a little facet that articulates with the tubercle of the rib, and this facet is here. It's called the transverse costal facet. And then the body has also costal facets in the upper and the lower edge, and these help for the head of the ribs to articulate in there. So these are the only vertebrae that has costal facets, because only the thoracic area, that's where we have ribs that articulates with them. The spinous process, which is this, I mean, it's not shown here really well, but in the lateral view, you can see that it's long, pointing downward. And then these carry the weight then from everything from above the 12 rib. So they are the second strongest. Now for the lumbar vertebrae, they have a flattened triangular vertebral foramen. They have the most massive body, and the transverse process and the spinous process are short, and the spinous process ends not pointed as and as angulated as the thoracic vertebrae, but rather it's more horizontal and it's broad when you look sideways, and it ends in a blunt ending. So here is the view from the different type of cervical vertebrae. This is the typical cervical vertebrae. I already explained the characteristics. In the transverse process, they have this transforamina, and then in the superior and inferior articular process, just as the rest of the vertebrae, with the exception of C1, which is the atlas, you have the superior and inferior articular processes that has these facets that articulates the superior with the inferior articular process from the lower vertebrae. In the case of the atlas, which is this, it has lateral masses instead of a body. And in these lateral masses, you have this, this is the top view, this superior articular facet to articulate with the condyles of the occipital bone. And then the inferior part, it has the inferior articular facets to articulate with the second cervical vertebrae that we know as the axis. So here's the axis. It has a body, and then it has this odontoid process. This odontoid process is the one that fits here into the internal part of the vertebral foramen in the facet 4 articulation for the atlas. And these two together form the atlantoaxial joint that it is stable in part by this transverse ligament. So then you allow the rotation of the atlas over the axis to do this type of movement. And then this part of this atlas, it is the anterior arch. It is shorter than, or less longer than this posterior arch. And then you have this anterior tubercle, posterior tubercle. In the case of the axis, yes, you have a body. The body faces inferiorly and the dens faces superiorly. Now, the last cervical vertebrae, it is actually the cervical vertebrae that the spinous process can be felt much easier posteriorly. So this is called vertebral prominence. This means like more prominent, like it's more evident than the rest. And that can be used as a point for counting vertebrae. So it's just found at the base of your neck. And then if you go down, touching the spinous process, then you can start counting. Well, T1, T2, T3, T4. Abbreviation for any of the cervicals starts with their first letter, capital C, and then the number. We have coccygeals. In the case of coccygeal vertebrae, you use the first letter and the second letter. And always the first letter is capital, so it will be CO. So you don't get confused with the abbreviation. And this is how you see all this articulating. So this is the superior, inferior articular processes making connections with these little facets. Any questions? Thoracic vertebrae characteristics, we saw it before, but let's look a little bit closer to it. So this is the superior view of these thoracic vertebrae. This is the lateral view. Again, these spinous processes are longer than any other vertebrae, and then they have a pointy ending. And then this is the superior articular process, this is the inferior articular process. Between the spinous process and the body, in the most vertebrae, we have this little notch that is called inferior vertebral notch. And this inferior vertebral notch, when two adjacent vertebrae articulates together, creates a little foramen through which the spinal nerve exits. And then for this thoracic vertebrae, you can see in this lateral view the superior costal facet and inferior costal facet at the edge of the body that is close to this inferior vertebral notch. And then in this transverse process, you can see laterally the transverse costal facet. Then of course you can see here between these two thoracic vertebrae this intervertebral disc that maintains the separation that is needed so that you don't have body-to-body friction. Then the body typically is described as having heart shape. For lumbar, so this is the top view, lateral view, and then two lumbar articulating together. Something else that is characteristic of this vertebrae, besides having a thick, massive body and having these short transverse and spinous processes with blunt end for the spinous process, is the fact that this inferior articular process faces more, the facet faces more laterally, and the superior articular process has the facet facing medially, and having this wide infravertebral notch, wider than the rest of the infravertebral notches from the rest of the vertebrae. So, do you have an idea of why we have these notches that allow the exit of spinal nerves wider in the lumbar area, but not as wide in the thoracic or in the cervical area? Why this part is wider in the lumbar, but not in the thoracic?
It's bearing more weight.
Because it's what?
It's holding more weight.
Well, this part doesn't hold the weight. It's the part that is the part that allows the nerves to exit, the spinal nerves. Why we have this wider in here? What? The hips are wider. No, it's not related to the hips. The cervical vertebrae has not as wide the notches that allow the spinal cord to spinal nerves to exit. The thoracic has intermediate size, but then in the lumbar we have wide spaces to exit the spinal nerves. Think about the size of the spinal nerves.
They're getting bigger.
Mm-hmm. They're getting bigger. So The nerves provide functions for our limbs and the rest of the body in general. The nerves that help us to move our muscles from our lower limb, they have to be bigger, because which limb is bigger, the upper or the lower limb? The lower limb. So we have wider nerves going through there. Now the ones that exits on the upper cervical vertebrae only help us to move the muscles and feel sensation, not only helping move the muscles, but also to provide sensation for muscles in the neck. These muscles are not as massive as these ones in here. So these supra or infraspinal notches are not as wide. Now for the sacrum and the coccyx. Sacrum is 5 fused vertebrae, and then they are lower, of course, to the lumbar, which we have 5 lumbars. So here's the anterior view of the sacrum. It has triangular shape. This is the posterior view. So this is front, this is back. This vertebrae has bodies, and these bodies are fused or eventually get fused. So this is the point of fusion that you can see anteriorly. So this is S1, S2, S3, S4, S5. So the point of fusion is called the transverse lines. And instead of having infravertebral notches, we have sacral foramina. So this is the anterior sacral foramina. So this part will be what it was, the transverse processes. And then it has this base and this apex. Triangles have a base and it has an apex, a tip. And on the sides of the base, we have this region that is called wings or ala. And anteriorly, S1, the superior edge, it has the most prominent part. So this is called the sacral promontory. There is a line that can be traced from the sacral promontory to the pubic arch that is used frequently in obstetrics to see if the head of the baby can go through, together with the line that goes between the 2 ischial spines of the left and right coxal bones. So this is the sacral promontory. And now the apex of the sacrum articulates with the coccyx. This is the coccyx, between 3 to 5 coccygeal vertebrae fused. Now in the posterior end, what you can see, it is an opening here next to the base. This is called the sacral canal. This opening is located between this anterior portion of the sacrum and this posterior portion, and then it narrows as it's going from S1 through S5, and this opening now, instead of being called canal, is called hiatus. It's a smaller opening than a canal. In the middle, in the posterior view of this sacrum, you can see the fusion of the spinous processes. This is called the median sacral crest. It's the fusion of the spinous processes. And then to the side, we have the posterior sacral foramina that, just as the anterior sacral foramina, allow the exits of nerves through these foramina. And then to the sides of this posterior sacral foramina, we have the lateral sacral crest. So if the median sacral crest represents the fusion of the spinous processes, what does this lateral sacral crest represents? The fusion of what part of the vertebrae? The lateral, the transverse processes. Remember, vertebrae has lateral processes that are called transverse processes. It has a medial posterior process that is called the spinous process. It has two superior processes that are the superior articular processes, and has two inferior processes that are the inferior articular processes. So this represents a fusion of the transverse processes. And now, on the side of these lateral processes, we have the lateral sacral crest. We have this articular surface that is called auricular surface. This auricular surface articulates with the iliac bone, part of the coxal, forming the SIJ, sacroiliac joint. This is the part where the axial skeleton articulates with the appendicular skeleton. Some people can have inflammation of this SIJ and they have pain here in the gluteal area or the upper part. And now, for the coccyx, it has some cornu or horns. This will be the coccygeal cornu, and they articulate with the apex of the sacrum. Typically, this bone is immovable, but it can be movable in females during delivery. And then, in general, this bone provides point of attachment for ligaments and muscles of the pelvic floor. Now, before we move into the next part, something that I forgot to mention, but I will mention again when we talk about the spinal cord, is that the spinal cord, guys, ends at the level of L2, lumbar vertebrae 2. Below that, we have nerves that runs between the L2 and the sacrum. But this point is important because if someone is going to have a tap, like withdrawal of cerebrospinal fluid, it is important to take that tap below L2 level to prevent damage to the spinal cord. Okay, the last part of the axial skeleton, the thoracic cage. The thoracic cage is made by the anterior single bone, the sternum, posteriorly the 12 thoracic vertebrae, laterally and anteriorly and posteriorly, embracing our organs like the lungs, the heart, major blood vessels, will be the ribs. The proper name for the ribs will be costa. We have 12 pairs, and they are classified as true, false, and floating. So for the ribs, the first 7 are true ribs, are also known as vertebrosternal because they use their own costal cartilage to connect to the sternum. The last 5 pairs are called the false ribs, will be pairs 1 through 12, and out of these false ribs, 8 through 10 are called vertebrochondral. Why they are called vertebrochondral? Because they run between the vertebrae and the point of attachment, which will be the 7th costal cartilage. They piggyback the costal cartilage of rib number 7. And then the last 2 pairs, 11 and 12, are called floating because they don't connect at all to the sternum. Function of these will be majorly to protect the kidneys, especially number 11. Number 12 is to give money to plastic surgeons. Some artists have taken out some ribs to look thinner, I guess. I'm kidding. No, that happened. That is true, but it's not for that. It's also for protection of the kidneys. Anyway, so these are the costs, the classification. Now for the sternum, we have three parts. The upper part that looks like a notch of a tie, this is called the manubrium. The manubrium on the top part, this part, it has this little indentation that is called the supra-sternal notch. And then on the sides has the clavicular notch that helps for articulation with the clavicle. Another name for this suprasternal notch is jugular notch. And then the connection between the manubrium and the second largest part of the sternum, it is Louis angle or sternal angle. It happens specifically at the second intercostal space. So this is the first intercostal space, this is the second. So this is where we have this Louis angle. And it's a clinical point because on the sides of the sternum, we can hear with the stethoscope some heart sounds for the aortic and the pulmonary valve. You will see that in AMP2. So then the next part of this sternum is the body or gladiolus. And then the last part will be the xiphoid process. This xiphoid process is typically in young people, is made out of hyaline cartilage, and over the age of 35, it becomes solidified. Some people can born without the xiphoid process, and they can show like a little hole there that is called the pectum excavatum. Nothing happens. A person don't have respiratory problems or anything, but some people can born without a xiphoid process. Don't ask me about the cause. Sometimes it's genetics. So functions of the thoracic cage in general is to protect the heart, lungs, and other thoracic organs. Support as well the shoulder girdle and the upper limbs. Provide attachment for respiratory muscles. In between the ribs, we have intercostal muscles, internal and external. And then we have postural muscles attachment and enables breathing by helping to horizontalize the ribs and also bring them down. The ribs typically are pointing downward. For the ribs, the name again properly is called costal bones. They have posteriorly the head, that it has some facets, the superior and inferior facets, that articulates with the superior and inferior costal facets of the body, of the vertebrae. And then this head will be followed by a constricted area that's called the neck. And then below the neck, we have a tubercle. This tubercle articulates with the transverse costal facet. And then after the tubercle, you have a sharp turn that moves the ribs body posteriorly and inferiorly. And this change in direction happens at the angle of the rib. So here is where we have the angle of the ribs. And then this will be the body or shaft. And then it ends in this blunt end, which is the point 4 attachment for the costal cartilage. And then below the body, you have the costal groove that allows the running of the vein, the artery, and the nerve, the intercostals. Any questions? Does males have more ribs than we? Nose. Okay, so now for the appendicular skeleton. So, what are the bones of the upper limb and why they are important? So, in the upper limb, we have in the arm a single bone that it is the humerus, and then in the forearm, we have two bones, the lateral bone, which is the radius, the medial bone, which is the ulna. So these bones are important because they help us to provide major movements in our upper limb so that we can manipulate the environment. We can grab objects, that food, for instance, for eating, or even to help us to maintain equilibrium, or prevent us from damaging ourselves when we are falling. So the humerus articulates with the bones from the pectoral girdle, or shoulder girdle, like the scapula, that is located here posteriorly, and the clavicle, which is found anteriorly. Now, specifically, the humerus has a head that articulates with a cavity in the scapula, which is the glenoid cavity. It's a shallow cavity, but that articulation is very important. Why? Because help us to do 360-degree movement. Is the most wide range of movement that we can do with an articulation. And then connecting to the forearm muscles, we have the carpals, forearm bones. We have the carpal bones that are found in the wrist. We have 8 carpals, not 7, that are located in a proximal row and a distal row. So we will see the names of these. Now in our hands, specifically in our palm, we have 5 metacarpals, and then in our fingers, we have 14 phalanges. The upper limb bones, they connect into this axial skeleton by the clavicle and the scapula. And these help us to have this proper connection so that our upper limbs will be always attached into the body. Another important point for these bones is that allows the attachment of muscles, protecting nerves as well, and blood vessels. And these are not complicated bones. They have less features than the skull bones. So that will help you to just think about that you have good grasp of this anatomy, and then you don't fear like, well, I have to learn a lot of bone names. Well, out of those 206, 208 that we mentioned, remember, most of them are paired. And some of them, they don't have special names, like these ones on the fingers or the metacarpals. You just name them according to where they are located, you number them, and that reduces the number of bones and markings that are not, for the most part, specifically naming, so that reduces also that load, cognitive load. Now, let's look at the markings of the bones of the pectoral or shoulder girdle. So we have here in this area of our body, anteriorly, the clavicle. The clavicle is a very thin, short bone that we have in the upper anterior part of our shoulder. And it has, if you look from the superior view, an italic S shape. So this is what you're looking at. So this is the head. So if you look at from above, it has a lateral portion and a medial portion. The lateral portion has this convexity. The medial portion, it is more flat in its ending. The medial end is called the sternal end. Why? Because it connects to the sternum that we have it in here. And the lateral end is called the acromial end because in the scapula, which is this posterior bone, we have this extension that is called the acromion. So that's what you can see in this superior part. Now, in the inferior part, like if someone was standing and then you look from below, you can see that next to this acromial end, you have a tubercle that is called a coronary tubercle. This allows for some ligaments to insert in there, and then if you look these connections then between the clavicle and the scapula, you would call these articulations accordingly. So the connection between the sternum and the clavicle is called a sternoclavicular joint, taking the names of both bones that makes this articulation. The connection between the acromion from the scapula and the clavicle is called the acromioclavicular joint. It's not called a scapula-clavicular joint. Sometimes you take the name coming from that specific part that articulates. Now for the scapula has almost a triangular shape, and it has a superior border, which is this part that it is located superiorly above. It has this middle border that is a little bit convex, and it has a lateral border that is almost straight. So what you're looking here, if you look at this part, you're looking at this anterior view. So in the anterior view, you can see these borders: superior, medial, and lateral border. The connections between the borders are angles. So between the superior border and the medial border, you have the superior angle. The connection between the middle border and the lateral border, since it's inferior, you call this inferior angle. And then the connection between the superior border and the lateral border is the lateral angle. Now, this is the body, and in the body, you have a fossa. This fossa is called subscapular fossa. And this is where some muscles insert, like the subscapularis muscle. Later on, we'll see in the muscular system chapter what this muscle does. And then coming off from this lateral angle and the superior border, we have a little process that looks like a bird's beak. This is called a coracoid process. And now, if you look in this lateral view, so see this body is oriented this way. So if you look at from this view, you can see the edge of this lateral border, you can see the inferior angle, and at the top of this lateral border, you can see a broadened area that is shallow. It's a cavity that is shallow. This is the glenoid cavity. The glenoid cavity articulates with the head of the humerus to form the glenohumeral joint, the shoulder joint. Because this cavity is shallow and this humerus head fits into there, and we have the most mobility in our shoulder joint, this joint is easily dislocated. It is reinforced with ligaments and muscles and tendons and some bursae, which are like little pouches with synovial fluid, but still this articulation can dislocate. Now, this is the posterior view, this is the anterior view. So here is where we have, below this coracoid process, this is where we have this fossa, the subscapular fossa. And then this little process that you see here is called spine. And this is the acromion. The acromion is lateral. So this is a posterior view. So you can see that the acromion, which is next to the glenoid cavity, is lateral. So this is a lateral part. Why? Because on the side, that's where we have our arm and our forearm. Okay, so this spine, it is the actual part that you can feel really easily if you do this. So the spine runs in an angle from the medial border to the lateral border going up, and then it broadens into this plate that is called the acromion. So posteriorly, above this spine, we have a fossa. In anatomy, supra means above. And since you are taking as a reference point the fossa, so this fossa, which is a shallow depression in a bone, can be named, because it's above the spine, supraspinous fossa. And supraspinatus muscles inserts into this fossa. So then how would you call the fossa that is below the spine? If the one above the spine is called supraspinous fossa, how would you call the one that is below the spine? Infraspinous fossa. And yes, that's the name, infraspinous fossa. The infraspinous fossa, as you can see, is larger than the supraspinous fossa. And infraspinatus muscles fits into here. And it's not labeled in here, but in this part, we have this notch that is called the suprascapular notch. Through this suprascapular notch, we have nerves, arteries, and veins that runs through. Any questions about the scapula? So really quick, the parts of this will be superior border, medial border, which is convex, almost a straight border, lateral border. They end in angle, so this is superior angle, inferior angle, lateral angle. Above the lateral angle we have the glenoid cavity. This is the body, and in the body we have the subscapular fossa. This is the coracoid process coming up from the superior border posteriorly. And then this is the acromion. Laterally, you can see the lateral border. This is anterior, so this is the subscapular fossa. This is posterior, so this is the infraspinous fossa. This is the supraspinous fossa. Glenoid cavity, coracoid process. You can see the superior angle here, the acromion. What you can see in this posterior view: medial border, lateral border, inferior angle, superior angle, lateral angle, the glenoid cavity, the spine going up in an angle, the acromion, the suprascapular notch, supraspinous fossa, infraspinous fossa. Questions? Humerus, it is medium size in length in comparison to other bones like our femur or our tibia, our fibula that are located in the leg. So this is the bone of our arm. So you are looking here at the anterior view. So this is the anterior view, and this will be the posterior view. So it has two epiphyses, proximal and distal. In the proximal epiphysis, something that you can see is this rounded projection. This is the head. Below the head, you have this anatomical neck. And then in the anterior view, you can see two tubercles. the one that is lateral, which is the greater tubercle, and the one that is medial, which is the lesser tubercle. In between the two tubercles, there is a little groove. This is the intertubercular sulcus. Sulcus is another name for groove. Through this intertubercular sulcus, we have the sliding of a tendon from this muscle that we have anteriorly in our arm. This is the biceps. So that bicep has a tendon that runs here in the intertubercular sulcus. And then below these two lesser tubercles, we have another neck that is called the surgical neck. It's close to the body or shaft, which is this, the surgical neck. The anatomical neck is next to the head, so it's a little bit more proximal. This is a little bit more distal. And then laterally, almost towards the middle of the shaft, we have this rough-neck tuberosity. This is called the deltoid tuberosity. This shoulder muscle, which is called the deltoid, inserts into there. And then in the anterior view, in the distal epiphysis, you can see here two fossas. One that it is less wider than the other one. So the lateral is less wider, the medial it's a little bit more wider. So the lateral fossa is called the radial fossa, while the medial fossa is called the conoid fossa. In these fossas, or fossae, you have articulation of the radius and the ulna. The radial fossa articulates the radial head of the radius. And the conoid fossa articulates the conoid process from the ulna. The ulna is medial, the radius is lateral. When these two fossas are occupied by the radius and the ulna, you have full flexion of your forearm over your arm. You cannot go greater than this flexion. You cannot go beyond this because these two bones stops there in these fossas. And then in between, you have a little line of bone that separates these two fossas. Now, lateral to the radial fossa, we have the lateral epicondyle, and medial to the conoid fossa, we have the medial epicondyle. Now, how will I know what is medial, what is lateral? Well, if you look here in the proximal epiphysis of the humerus, we have the head, and the head faces medially. So one way to not even know here in this distal epiphysis what is medial and what is lateral, but also to know maybe if this is a right or a left humerus is by looking here, the head. The head always faces medially because it has to articulate with the scapula. So then, if you just slide your eyes below, looking at this area, so this will be the medial epicondyle, while this one will be the lateral epicondyle. And then the most distal part, anterior part of this humerus will be the capitulum, which is a rounded projection, and then the trochlea. In the trochlea, we have the sliding of the ulna. And in the capitulum, we have the sliding of the superior part of the head of the radius. And this one is rounded so that you not only have a smooth flexion of your forearm over your arm, but also you can supinate or you can pronate. So if you're working out with dumbbells, if you want to work out better your biceps, rather than just doing this movement, flexion and extension, that is very straight, you can do this and also like medially rotate your forearm. This is called supination. So that improves the working of this muscle. Any questions about the anterior view of the humerus? Now for the posterior view, similar features. You can see the head, you can see the greater tubercle, but not the lesser. And then you cannot see this sulcus, but you can see the anatomical neck, the surgical neck, a little bit of the deltoid tuberosity here, and then you can see a groove that runs from anterior to posterior. Is not well shown in here. That is called the radial groove. We have a major nerve that is called the radial nerve that runs in there, next to the shaft. When it comes to nerves, and major arteries, they tend to run next to the shaft of bones for protection. They are burrowed within the muscles. So then we have here the radial groove, and then, of course, this is a shaft. And here in this posterior part of the distal epiphysis of your humerus, you have the largest fossa of the three fossas that your humerus have. This is the olecranon fossa. In the olecranon fossa, you have the fitment of the olecranon process, which is your elbow bone. It's part of the ulna. So when you have completely extended your forearm against your arm, like this, your olecranon process stops there in this olecranon fossa. And then, of course, if you take as a reference point your head, which faces medially, and you go below to see what you have here, this will be the medial epicondyle, and this will be the lateral epicondyle. And then below the olecranon fossa, in between these condyles, we have the trochlea. The trochlear notch of the ulna slides over this trochlea, which is like a pulley-like connection. Any questions? So that's the humerus then. For the radius and the ulna. So these are the forearm bones. Again, ulna is medial, radius is lateral. They form the radioulnar joints, the proximal and the distal. And in this proximal part of the ulna and the radius, this is the radius, this is the ulna, you have this radial notch of the ulna that fits the head of the radius. So this is the head of the radius, and then just lateral to this notch of the ulna, the radial notch of the ulna, we have the coronoid process. So you can see it here. So this is the anterior view, this is the posterior view. So this is the coronoid process, which you can see here as well. This is the one that fits in the coronoid fossa anteriorly in the humerus. And then this is the trochlear notch. This is the one that slides on the trochlea of the humerus. And here's the olecranon process that fits in the olecranon fossa posteriorly in your humerus. So you can have flexion, extension of your forearm. And it is not well shown in here, but the radial head superiorly has a little indentation that it is concave. That little indentation fits the convexity of the capitulum so that you can do this movement. Pronation, bringing your palm down, supination, bringing your palm up. So that's one of the characteristics of this head. It has a concavity. And now below this radial head, we have this neck, and then medially to the neck and a little bit below, we have this tuberosity of the radius. It's called the radial tuberosity. So our biceps distally inserts into here, into this radial tuberosity. So if you flex a little bit your forearm and you start looking here, feel some tendons, those are the tendons of your biceps. And then if you go, try to follow them up and see where it's inserting, that will be the radial tuberosity. And then we have both the shafts of the radius and this ulna. The shafts are held together by this membrane. This membrane is called interosseous membrane. Inter means between. What does osseous mean? Bone? So this is the membrane between the bones, interosseous membrane. When we start talking about muscles, we will bring up again this membrane. What is its importance? And then distally, we have the distal radioulnar joint, which is made by the ulnar notch of the radius and the head of the ulna. So this is the radius. The radius has this broad projection in the distal part that ends in a tip that is called the radial styloid process. And then medially, this broad part of the radius has this notch for articulation that is made for the articulation of the head of the ulna to make the distal radioulnar joint. And then laterally and inferiorly, this ulnar head has a little extension that it is called the styloid process of the ulna. A styloid is needle-like projection. The ulna is not the only bone that has a styloid process. Also, our temporal bone has a styloid process. And this is the view posteriorly, so you can see the olecranon process. You can see the head of the radius, the shaft, the interosseous membrane, the styloid process of the radius, the styloid process of the ulna, the head of the ulna. The head of the ulna is very easily seen. So this is the head of the ulna. And then this is the styloid process of the radius. Any questions? For the hands and wrist bones, so in our hand, in our wrist specifically, we have this set of bones, which are called the carpals. The carpals, they have their own name. Some of them, they have certain markings. And if you look this is the anterior view of our hand. This is the posterior view. So, the thumb in the anatomical position is lateral. So this is the right hand. So it's like looking like this, okay? So from lateral to medial, the proximal row has the following bones. So it is scaphoid, lunate, trichetum, and pisiform. Sally left the party. Scaphoid, lunate, trichetum, and pisiform. That's the proximal row, from lateral to medial.
Are the last two stacked on top of each other?
Yes. The pisiform, it is on top of the trichetum. And then the distal row, it is trapezium, trapezoid, capitate, and hamate. The hamate has a hook, which is this one. So it will be Sally left the party to take Carmen home. Trapezium, trapezoid, capitate, hamate. Scaphoid articulates mostly with the radius, while the lunate articulates with the ulna. And now for the first two, which are the trapezium and the trapezoid, articulates with the first and second metacarpals. The metacarpals are numbered from medial to lateral 1 through 5 with Roman numerals. And then for this big carpal, the capitate, articulates with the third metacarpal, while the hamate articulates with the fourth and fifth metacarpals. So that's the anterior view. In the posterior view is the same. So you have from medial to lateral these bones, and then you can see these articulations with these metacarpals. Now the metacarpals proximally have the base, and then distal to the base will be the body, which is the longest part, and then they have these broad projections, which are the heads, which forms the knuckles. And now the head of these metacarpals articulate with the phalanges. Every finger, which are numbered, by the way, 1 through 5, medial to lateral. So every finger has proximal phalanges. So these are the proximal phalanges. And from fingers 2 through 5, they have middle phalanges. And all the fingers have distal phalanges, 1 through 5. The only one that is missing, the middle phalange, will be the pollex. So it only has proximal and distal phalanges, but don't have middle. But fingers through 2 through 5 has middle phalanges. And of course they have proximal and distal phalanges. Any questions? So next time we will be looking at the bones of the lower limb and also the bones for the pelvic girdle.